Our next speaker is Dr. Satchit Balsari, who is a fellow at the Center for Health and Human Rights at the Harvard Chan School of Public Health and is also in the emergency medicine faculty at Beth Israel Deaconess Hospital. Satchit.
Thank you very much, Larry. And thank you to the Harvard Global Health Institute for this invitation. My world is not your world. It is not the world of pandemics and epidemics. I'm an emergency medicine physician, but have had opportunities to work for long years in disasters, mass gatherings, and humanitarian crises, where we have struggled with disease surveillance for a long time. These are populations on the move. They are large, dark pockets of absent data. Building off what Nancy said about the opportunities that we have to take advantage of the new data streams available, I think the greater challenge in many of these populations, and we're not talking about hundreds of thousands or tens of thousands, but millions of people now on the move, is interpreting the scant data that do come out of these populations. On the last map that we saw of emerging disease hot maps, the two big green areas that light up are India and Western China. So I'm hoping to share a few illustrations from these areas to shed light on the challenges that we are going to have with surveillance and the opportunities for some new data streams. The photograph that we're looking at up there was on a day that to date marks the world's largest human gathering. There were 30 million people at one spot in the city of Allahabad in India in 2013. They had come for the 55-day-long religious festival called the Kumbh Mela, attended by about 80 million people over a period of 55 days. Now, if you've been to India, I think you realize very quickly that it is hard to find space to squeeze in 80 million people. and they do it quite brilliantly. Traditionally, this festival occurs at the confluence of two rivers in India, and when the waters recede, about 50 square kilometers of the sandbank is exposed. On it is constructed a temporary city that hosts about 1 million people, pilgrims essentially, that come from all corners of India to camp out. And several million others will travel in and out of that township over the next 50 days. The goal is to dunk in the river essentially at the confluence, because that holy dip will guarantee you nirvana or liberation from this persistent cycle of life and death. As scientists, when you look at these tens of millions of people who have gathered there, sharing their food and bathing together in this communal spiritual spirit, you cannot but help also think about the trillions of germs that they brought with them that are going to intermingle. And you wonder how surveillance is going to occur in that region. This was a team from Harvard. It was an interdisciplinary team that had gone there. And you're looking at an aerial map of the Kumbh Nagari, or the township, where the government had put up 14 to 15 clinics, primary care clinics essentially, where the doctors saw about 600 patients in 8 hours. You had just about enough time to hear what the patient was telling you. I'm here with a cough. You may not even look up, and you will scribble something very quickly in that little notebook. Now, physicians, as you know, spend somewhere about between 4 to 6 years learning how to write illegibly. So captured in that little line was the chief complaint. Just about enough for syndromic surveillance. It was 2013, we decided to employ the world's cheapest smart labor force, medical students, and put them next to all these notebooks and had them transcribe these data into tablet computers that had just sort of come out in India and borrowed to mobile hotspots from local families. Long story short, we were able to essentially conduct syndromic surveillance by using cloud and mobile technologies. Very simple intervention, but suddenly for the first time at the Kumbh Mela, these very large mass gatherings, you had some sort of data beginning to show up. There are, of course, many challenges with them. Where is the baseline data? What are you going to compare it to? The denominator keeps changing. But by 2015, the government in a different state in India had replaced the paper forms with the tablet forms. And what you're looking at is an interactive dashboard that the public health officials had used. You could query it, you could click on particular spikes, and basically get more information on the epidemiology of the patterns that you were looking at. I'm going to switch gears to something that was a little bit more unpredictable. In the humanitarian world, over the last few years, there have been a lot of publications, a lot of research, a lot of conversations around the world about the struggle with data interoperability. You are looking at different towns, different countries, different cultures, different languages, and trying to make sense out of these data as millions migrate, mostly forcibly. You have injections of large populations in very small swaths of land. Lebanon suddenly gets 1 million, 1.5 million, with a baseline population about 4 million people. In Cox's Bazar, on the southern strip of Bangladesh, we now have 800,000 Rohingya refugees camping out only since August 2017. Again, these people, these hundreds of thousands of refugees, move with their own antimicrobial resistant patterns. They come into host communities with different host diseases that are endemic and with different levels of vaccination. So while we were having conversations globally about data interoperability, what was happening on the ground in Syria was that the Syrian American Medical Society, having recognized that there were better ways to collect data, had trained their doctors in these underground hospitals that we've all read about, the 150 clinics that sprouted up in Syria, and they constantly moved as they were being bombed, and they were physically underground. And in spite of sort of those extreme situations, they had these physicians log some kind of data, which gave us, or which would give us, really critical information about the epidemiology, the burden of disease in these clinics, whether non-communicable or not. And of the 2.5 million patient visits that we helped the Syrian American Medical Society look at from the last 2 or 3 years of the data that were collected, we found that the data were available to us in 38,000 different formats. Because one Excel sheet from another, even if a column moves, as data scientists, many of you understand that that is hugely problematic. Every time there was a new program officer that realized that they needed one additional piece of information, something else moved. And it didn't matter that you were great at Python, you also needed to know how to code the script, not only to go left to right from column to column, but then actually translate the Arabic right to left. Right? So there are huge issues when we try and sort of make sense of how. This was 2.5 million patient visits, right? A large amount of fairly useful data that we would get as this population was moving. But just interpreting that took about a year of several smart people from around the globe trying to make sense of these various data sheets that they were looking at. In peacetime, at a simple primary care clinic in India, this was after the Kumbh Mela, we said, well, how is baseline data then collected? How does it get into DHIS2? What is reported to the WHO? Where do these data come from? We just did a simple survey of all the forms and books that community workers and primary care doctors are filling out at a primary care level. We found that they collect about 3,800 different data points across 170 different forms. And if we tried to sort of map these, you found that there was a great amount of redundancy, and the same data showed up in multiple forms. And if you try and map everything, that's sort of what it begins to look like. I think there are tremendous opportunities to do this right, and technology will play a very critical role here. But we have narrow windows of opportunity before these billion-dollar medical records start landing up in the developing world, creating the same vertical silos of data that we have here. as Nancy rightly said, it shouldn't have been so difficult to make all these data interoperable. There is some promise. In India, just 3 days ago, the Supreme Court upheld the constitutionality of their universal biometric ID system, which is going to be tagged to what developers there are calling the National Health Stack. In plain English, just like our phone apps all communicate with each other, Instagram will talk to our camera irrespective of the make of your phone through little packages of code called API. What scientists in India are hoping to do is to create an API-enabled health information ecosystem, which means that all these data will talk to each other even though they sit at source. So as a public health agency, if you want to do lab surveillance, you should be able to call lab data from across the labs in the country. It's bold, it's audacious, it's wishful, it'll probably not happen. But there is hope that it will, because over the last 10 years or so, they've been very highly successful with building a technological spine for financial transactions in India. And it is the same team that wants to expand this spine to healthcare. I have probably overshot my time, so I will leave us with this thought that the greater investments therefore will need to be made at the primary care health level. I think we've realized what we have done with vertical programs over the last couple of decades. I think the same kind of verticalization is now showing up with data streams in the developing world. Across Africa and India, you will find community workers walking around with 2 or 3 tablets because different philanthropic foundations have sponsored a new app that they should be collecting their data in. And there is a window of opportunity here to do it right. Strong basic systems play a tremendous role, as certainly this crowd understands, in helping us mitigate a large public health catastrophes. The map that you're looking at is one that I want to leave us with. The graphs that you're looking at on the right are vaccination rates in the Rohingya camps in Bangladesh. You essentially found that you had these tens of thousands of children that came in with almost zero vaccination in Myanmar. But you had a very proactive surveillance system that picked that up, that recognized that very quickly. You had the WHO teams, the UN agencies, and a powerful Ministry of Health and local NGOs that had the capacity to go in and do multiple rounds of vaccinations. And therefore, we have not seen the kinds of disease outbreaks that we should have seen by now in Cox's Bazar. Thank you for listening.